All right, so thank you so much, Manu, for being in conversation with me, and to T, and to Terry, and to Dory, for all the organizational work. I mean, I think it's become an extraordinary thing to organize an in-person and hybrid event in these times, and it is such a pleasure to be able to come back and be in this community. I haven't visited the United States since 2019, and it really is a pleasure to be back, and with such great friends. So thank you so much. So as I suppose the overview of the book describes, it's a case-by-case study of how racism impacts health in the United States. And it's specifically about anti-Black racism, and we can talk about why I chose that particular focus. But what I've done is a little bit different from the way that we conventionally teach that. So I've taught a lot of classes, including here at Georgia Tech, and topics such as science, technology, and race, and biomedicine and culture. And usually when we teach about racism and health, we kind of do it starting from colonialism and slavery, and then kind of move forward through time. And I found that there were a lot of problems with that in my classroom. So one was that it was really remote from students' experiences when we started. And so it was kind of hard for them to engage. But also, some students got the impression, wow, I sure am glad I'm not from the past, where there was all that racism, and now I'm in the present and the future, and not really getting that opportunity to think about what role they could have and what was going on to prop up unjust systems. And so what this book does is looks at 6 case studies that are all from the 21st century, starting from the postal workers who died in the anthrax attacks. Amazingly little remembered now. I mean, I think maybe not amazingly, because obviously September 11th, 2001 was a huge kind of moment in American history. But at the same time, these anthrax attacks that happened the following month seem to have been forgotten. And so that's the first case in the book. Moving on through Hurricane Katrina, but with a special focus on the impact of chronic disease. And then on through different cases through the 21st century that each illustrate different elements. And so that's kind of the core story of the book. And it is hard to pick a favorite. I think maybe it would be the first one, just the case of the postal workers. And I think maybe it's because it's the one that has haunted the whole book's process. So I started my PhD in 2001. September 11th, 2001 was my first day of social theory class. And so it was this moment that I was starting my kind of PhD inquiry. And for me, this case was something I started thinking about then. And I've always been amazed that other people, it wasn't as resonant with them. For me, it's been something that has really foreshadowed the Black Lives Matter moment, especially because the way that I came to know about it was that there was a 911 call that one of the postal workers made. And by the time that we heard the 911 call on the radio, we already knew that the postal worker had died of anthrax. And he describes in his 911 call his repeated efforts to try to get access to health care and to try to get answers from his governmental employers. And so, this really, for me, became a case that informed the way that I understood the others and what it means to even be an essential worker, right? It doesn't mean that you are considered to be essential. Instead, it means too often that people are considered to be disposable. Even though, one of the things that really comes through, especially in the Postal Service in Washington, D.C., which is a really important institution of Black middle class. I think that it's not just, I think there's so much in the book about the ways that class and race are inextricable in the United States, and that's no accident. So Kamara Jones, who's been an important kind of interlocutor and really informs a lot of my own thinking. She ran the CDC working group on racism and health, and in these periods just after this, would emphasize that as well, right? It's not a coincidence that race and class are kind of overlapping, mutually reinforcing, and yet I think that the attention to these middle class postal workers and the way that they were treated like disposable and relative to the Capitol Hill workers, right? It's just such a stark such a stark case.
Yeah, no. And again, to bring it back, I think not all of that was in the news and in the public at the time, that then it was great for you to bring that up. But I also want to bring that back to the current time. I mean, you you cite a quite funny joke in the book. I can recite it, or would you like to recite it, and then I'll comment?
Oh, you go for it.
Well, you said, what do you call a white man who's giving 10 black men instructions? Quarterback. And what do you call a white man who's giving 10,000 black men carrying bags instructions? Postmaster General. And I think about today's time with Louis DeJoy, our Postmaster General, who I think we all have seen has been on this pathway to destroy the post office. And he was selected over, I think there was an African-American man that was the obvious next. So it goes back to this racism with the post office, but I'd love for you to speak about that in terms of delivering healthcare, delivering medicine, drugs to the elderly. If you could speak on that and how even the Postal Service today is manipulated or racialized with these.
Yeah, I mean, the profound disinvestment in infrastructure is really interconnected to the disinvestment in whole groups of people. So we see this with the Hurricane Katrina case, also with the Flint water crisis. Again and again, we see that this kind of financialization pressures, these really short-sighted understandings of ROI and of what can be afforded and what can't be afforded, what all of a sudden is some kind of affordability crisis, means that we can't do what's essential. And we see this, happening again and again with in the COVID crisis. And I mean, the timing of this book is kind of extraordinary because so as I mentioned, I really started thinking about these things in 2001. It's been a long time. I mean, my previous book was only published 2 years ago, but I didn't write this in 2 years. And those of you who know academic publishing know that I didn't start writing it during COVID and then have it out now. Instead, I turned in the draft of the manuscript in January 2020, went out for peer review and got some feedback, and then I was working on the final draft in summer 2020. So all of these themes were so prominent on my mind. So as I was doing the final revisions, and then, of course, in the introduction and the conclusion as well, the way that these really pernicious disregard and structural and infrastructural disregard for people was happening in summer 2020 in ways that have been happening, and so not only in the 21st century, but also in the 21st century. And so I think one of the things that's really a prominent element of the book is connecting these like kind of crisis moments, these flashpoints, these controversies to the normal and the slow violence that is constantly impacting the very same people.
And it's a shame that they are still so relevant. But it's interesting, as you mentioned, this is mentioned in the beginning, I'm a biomedical engineer, natural scientist, right? And I was forced to take history classes in my schooling. And I was told you take history because in history you're doomed to repeat it. Seems like that's do as I say, not as I'm told, kind of deal. But I want to get back to how this delivery of healthcare and delivery of medicine particularly, how that gets back to your chapter on Hurricane Katrina. I love New Orleans, many people do. And again, to be a cognizant adult at that time was to watch the horror of how the people were treated. But what you really get into with affecting the medicine and health, how people were not getting access to their medication and how that wasn't really at the forefront of thought, which didn't, at least in my view, make the public news about how these people would be dying later because they weren't having access to medicine. Could you just speak about that a little bit more?
Yeah, I mean, so obviously Hurricane Katrina is remembered, right? So it's a real contrast to the postal workers case and others in the book. But this particular element of it was just something that struck me at the time of how at the very beginning of the wake of the storm, there was anxiety about infectious diseases and, were there going to be these waterborne disease outbreaks? And that was really not a significant impact on the morbidity and mortality of Katrina. So, instead we saw that there was acute drowning, right? And there was, there was the impact of the initial storm. But then afterwards, what we saw was a huge increase in the impact of chronic disease, so especially heart disease and diabetes. And, these are the underlying conditions, of course, that we talk about all the time in COVID. But those underlying conditions are themselves products of structural inequality, right? So they're not somehow essential, but they are built in. And in that chapter, I'm particularly attentive to the disruption of pharmaceutical flows. But one piece of that is acute. So I heard an account, my first book was about race and heart disease. And I'm very interested in the history of the ways that race and heart disease, the narratives of them were intertwined from the founding of cardiology in the beginning of the 20th century on through the 21st, and they've changed quite a bit. But early on, this kind of question of like what would be the impact on heart disease was not prominent on other people's minds. May have been on yours.
So what she's talking about, I had a little beef with her in one part of this book, which I'll just say and you can then address it, was she brings up, she's telling the history of it, which is fantastic. She says at one point in the book about how chronic disease wasn't usually being applying to Black people.
All the Black
Every
people
Black person I know are worried about chronic disease. And so I let Anne explain the contextual part because we had to talk and say, wait a minute, I don't know if I like this point.
Yeah, so this is a real historic change. So in the founding of cardiology, this was in the first half of the 20th century, mostly between World War I and II. There was this idea that heart disease was a disease of modernity, and so that was only something that modern people would have after infection was at bay. And so I think now obviously that's not the dominant narrative. I mean, cardiovascular disease has absolutely been democratized. And if anything, it's understood to be racialized in the other direction rather than being seen as kind of a marker of the elite. So I think that there's some of that old version there, like with the executive, the type A. I don't know. There's not completely gone, but I agree with you about that. But I think that, my route in for Katrina then was through the Association of Black Cardiologists. And one of the cardiologists that I heard speaking at an ABC conference described his own experience of first, so he's a New Orleans-based cardiologist, a Black cardiologist. He took his family to safety and then returned to the Superdome to attend to his patients, and found that some of them reported to him that they had brought their pharmaceuticals in like the Sunday, Monday, Tuesday, Wednesday, Thursday, Friday, Saturday pack, and the National Guard had confiscated those drugs and discarded them. And because you couldn't have drugs outside of their original packaging, that would be at risk of, kind of fostering drug abuse. Now, this is an extraordinary thing, and I haven't been able to find much corroboration of this. I don't know how widespread it was. But no matter the scale, it's such an outrage, and it's so indicative of this problem of seeing the way that the people who were impacted by Katrina were not seen as patients in need of care, but instead as potential criminals.
And you actually cite that. I mean, once a person who studies chronic diseases, we know that once people get off the medicine, things can really get on the tilt. And you report in the book that the rises in heart attacks and cardiovascular disease has never come back to the pre-Katrina levels in the city. I skipped over this in the post office part, but I want to come back to this and thinking about access to the medicine, as you just brought up, that were being taken from the Superdome, but then there's just the access and what one might be prescribed. And you really bring up some contrasts in the first chapter, back to the post office chapter, about how ciprofloxacin is an antibiotic that people could have access if they wanted to be protected from anthrax. But you again contrast that with the Black postal workers trying to get medical treatment. And again, that first chapter is really shocking for those that haven't read the book yet. And you talk about when we were both first-year grad students, but you were at MIT and you knew several other students who were like, we can just go Cipro whenever we want to.
Yeah.
But the Black postal workers, it was being denied. Can you talk about this access to healthcare even when requested?
Yeah, I mean, it was a poignant thing to me because I happened to attend a talk by a Pfizer middle manager at that time at MIT, and he was like, oh, anybody in this room could access Cipro if they wanted to. And I was like, well, why is it that the people who have a real need for this pharmaceutical in an emergency are denied it? Even when they go to the doctor and say, I work at this postal service, I believe that I've been exposed to anthrax, and even then are denied. And in some ways, it's not shocking. I mean, I think the way that it is shocking in that it's an outrage, and I think that this is a fundamental element of the book, right? That these things are sickening in that they're outrageous. They're also what make us sick. But I think that, it's something that pervades. So in the Katrina chapter, I also talk about the way that there were these drug donation programs that the pharmaceutical companies ran. They weren't the drugs that were needed. So what was needed was insulin, was, just like other things for chronic diseases. And what was given was just like halfway expired stuff, the same things that, both of us work also in global health context, same kind of treatment that you would expect there, right? And so, real disregard for giving people what they actually need, and instead just...
But Anne, they're such good companies. They're donating medical supplies to people. Am I missing something?
For a tax write-off, yeah. Mm-hmm.
Yes, for a tax write-off. So there's this whole thing about capitalistic philanthropy and ways that people use it. And it just kind of, for those that write about it, flips things on his head. And get it out of us. We'll actually be speaking at Emory tomorrow, not to give a plug out, but he's one of the people who talks about this philanthropy and how people are tricky with it. But back to the Cipro and access to drugs, because for those that don't know, Anne and I also know each other well when she was at Georgia Tech, because we were part of a working group on race and racism and contemporary biomedicine, and like Jen Singh and Scene and others were in that group. And one thing that you all taught me in that group, because it was, as the natural scientist, learning a lot from the social perspectives, was about this access to medical care, and sometimes it could be a benefit for the racism in medical care. And I looked at the Cipro. For those that know, Cipro can also cause tendon damage in children or in elderly populations where it can just wear away the tendon. And so when I read this piece of the story about how multiple people were taking Cipro, weren't exposed to anthrax case, I have concerns about who then had tendinopathy. But it likened me back to the opioid crisis, which we talked about back in the day. And if you could speak on that, I won't take your thunder, but about access to opioids and how that saved African Americans.
It is a real problem that pain is systematically undertreated in African American patients. And so this is, it's a crisis. And yet there is a protective element to that with regard to the opioid crisis, because we saw that the over-treatment of pain in some white communities really fed a lot of addiction that has been really destructive. And we have a colleague, Jonathan Metzl, at Vanderbilt, who we went to a conference of his and had all these ongoing conversations, but he's very interested in the way that racism actually also harms the health of white people too. Because, so part of that is because white people don't want to support the implementation of health policies that would benefit everybody. And so things like gun control measures and so on, right? And that is rooted in racist ideologies. And these drug cases are a really poignant case of that, right? Like, it's a really stark thing of like, your insistence that you be given every drug, but that other people need to be war on drugged, right? Then, that kind of, that's not good for the health of anybody.
Right. No, it's absolutely not. So now we'll move on to your next chapter, which again, story I had never heard of, actually.
Wow.
And I didn't want to be into the chapter when I started reading it, but the way you write draws you in and draws connections to things I know today. So can you tell the audience a little bit about the Scott sisters story?
Yeah, so this was an amazing thing too it was this topic of quite a bit of civil rights activism in around 2010, so this was a case of two sisters who were serving double life sentences, Mississippi prison, over a trivial crime. And they were more than a decade into their sentences. There was a lot of civil rights agitation to get them released. And, the kind of the main line was, the sisters may or may not be guilty of a role in an armed assault where no one was injured, but the state of Mississippi is absolutely guilty for keeping these women in prison for so long. And so there was a lot of kind of activism around the case. And then, but the governor of Mississippi wanted to be a presidential contender. And this kind of wasn't a good look, to have Mississippi looking backward in this way. And he came up with kind of an ingenious way to release the sisters without acknowledging wrongdoing, which was that one of the sisters needed a kidney donation. And so he suspended their sentences conditional upon one sister donating her kidney to the other and not pardoned them, right? So,
Pardon them.
but, and his statement is just extraordinary if you read it. It's just the kind of news speak that is just so warped as he talks about how the sisters are no longer a danger to society, so therefore they could be released, and their medical care costs a lot for the state of Mississippi. And so the state of Mississippi would save money by releasing them from prison. And so this points to a really perverse element of healthcare in the United States, that the only people with a constitutional right to healthcare are prisoners. But the care they receive is horrific, and that's why.
Because, wait, I got to get the catch point. She could not donate a kidney to her sister because she was in such poor health herself,
Yeah.
even though both of them had been in the penal system
Their
for
whole adult
15
lives.
years.
Yeah.
Speak on that. What does that say about healthcare in the prisons that is constitutionally mandated, what the prisoners receive? And again, during our working group, we did a whole piece on prisoner justice. Can you just enlighten the audience more about that?
Yeah, I mean, on the one hand, right, this is maybe another, it's connected to that stuff that Jonathan Metzl talks about with his, the concern about not treating prisoners too well or something, right? So, okay, they're obligated to, but then don't treat them well. Incarceration is terrible for your health, especially long term, right? And so the food is terrible. I mean, so Tony Hatch has written about prison food and the way that it wears down bodies. Obviously, the kind of social condition of life in prison does the same, right? But these sisters were obese and sick in many ways by the time that they were released. And then, so the sisters couldn't donate the kidney to the other. Eventually, the one who needed a kidney received it from elsewhere, and they moved to Florida. So they're no longer a cost to Mississippi at all.
And again, to bring it current, it takes us back to when COVID started to spread. It was spreading in prisons. There was release of certain prisoners from the jail cells, and then others were just kept in rooms together, and COVID was running rampant.
Absolutely.
Things are still happening. So we're going to move on again because, my goodness, you've got some great story vignettes. And this other one with Dejaria Becton gutted me. Not just the chapter, but watching the video live and then watching it replayed on social media. But love if you could give the audience just a quick synopsis of this.
Yeah, so this, I mean, you may not remember the name, Dejaria Becton, but you probably remember the viral videos, which this was a case of a young girl, 14 going on 15, that who was at a pool party in McKinney, Texas, an upscale suburb of Dallas, and she was tackled by a police officer in full uniform and pinned to the ground. And the video was distributed by a classmate, right, who took a video at the time, a white classmate at the same party, took a video at the same time at the time and posted it online. It was widely shared, and I think, it's just, this is the least medical chapter of the book. I'm not really talking about something that happens in a medical environment. It's not about the deprivation of pharmaceuticals, whether delivered at home or whether in the hospital. And yet it's about the control of bodies too, and the control of space. So segregation just has such a tremendous impact on health, including in middle-class suburbs and upper middle-class suburbs like McKinney. And then also, the pool, this is another example of where, I feel like I kind of downplay history, but I don't really, right? It's just using the contemporary as a way to reach into the history. And the history of the segregation of pools has been such a touchstone of the segregation of access to urban space, access also to health and flourishing, right? I mean, so pools were originally understood as a hygiene kind of amenity in urban spaces, and then became these technologies that would be a space of recreation. And recreation is important in bodily well-being.
And you said something here I just want to jump on too, because I love the subtitle of this chapter. It actually made me step back, reread it again, and make sure I was looking at the right thing. You call it the Suburban Pool as a Technology of Separations. So we're here at Georgia Tech, World of Technology. And it really challenged me to think about the pool as a technology. And then later on, you say swimsuits are blatantly technologies of gender. And so you really, to me, have kind of redefined technology. So can you kind of share how you use technologies as you describe your work?
Yeah, this is a fundamental element of my field, I suppose. So science, technology, and society is where technology is in this kind of domain, society made durable, right? So anything that is used as a tool, that is, you get anything could be a technology. Even words could be technologies and so on, right? Categories are technologies. I mean, anything could be a technology. Anything that's a means of doing something. And yes, swimsuits are a good example, right? That juxtaposition of the police uniform as a technology that is already violent even before the incident happens, and the swimsuit as this kind of marker of a kind of feminine vulnerability, but also probably joy. I mean, like, it was a really fun swimsuit, right? Like, there's pink and orange, and there's a beautiful piece in a fashion sociologist has written about that kind of that juxtaposition of like how those things that bring joy, and fashion can be a technology of joy, also in this case becomes like a real kind of marker of that vulnerability.
And then what does that young girl associate with that joy technology for the rest of her? It's a fascinating read, and it was just a horrifying time. I'm going to move on to our next chapter, but I think the other point that you punch home that really hits me in that chapter is how it was shared so widely. And just to imagine this 14, 15-year-old girl in this vulnerable position in this swimsuit technology, and it's shared everywhere. It just really puts a different lens on it, again, for me. But in our last bit of our moderated time, we have to talk about the final chapter with Serena Williams. Now, she does do a great chapter on Flint, Michigan, and General Motors, and how the importance of protecting the technology and the metal was more important than protecting the people. But I do want to make sure we give some great time to the Serena Williams discussion. So please.
Yeah, so this one I think is another one that is more familiar to people, right? So people have heard a bit about it, and it's because Serena Williams herself has spoken out about this. So, she nearly died in childbirth and really described facing a real struggle to have her concerns taken seriously. So she knew that she had a blood clotting disorder, that for her having a C-section would be quite dangerous, that she would need particular monitoring. She's highly aware of her body, obviously, and and described exactly the drug that she needed. And yet her concerns were dismissed, and she described the way that, okay, fine, she eventually was successful and she survived. But you shouldn't have to be a superstar to survive, right? So, to have to be Serena Williams in order to survive, and even for Serena Williams, it's hard. I mean, it really shows. I mean, so it's such an important kind of example for thinking about the way that maternal morbidity and mortality and infant morbidity and mortality is so racialized in this country at all class levels.
Very important. And the part that really gets me about the Serena Williams story, even when it had happened, I was reading about it, but the way you categorize in the book, it scared a lot of people I knew at the time, because she's the epitome of fitness. So again, we talked earlier about Black people and chronic diseases, and that's across men and women who are told that pregnancies might be dangerous. Statistics on Black maternal morbidities you brought up scared people, and it's like, if Serena Williams is the epitome of fitness and who has all the money to get the best care,
all the power
can have this, what's going to happen? And I think now there's been more studies that have come out about the risks of Black maternity and morbidity and Black infant mortality. Again, at the conference that we went to at Vanderbilt with Netzel and several of our friends in the audience, Melissa Harris Perry actually gave a really stunning talk where she talked about no matter the education level, the income level, there is still a major gap in infant mortality between Black women and white women. I'd love it if you could add any comment to that.
Yeah, I think that, it's such a kind of stark indictment of the medical system in the United States. I mean, so in global health, it's kind of maternal and infant markers are really prominent in like is the healthcare system working at all? And these numbers are really canonical. And so it is an indictment of the US system. And I think that they are, it's a real kind of social justice question. And I think that for me, the reason that the book, it sounds like it could be such a downer, and it is in some ways, right? I mean, it's a harrowing set of stories, and yet it becomes such a powerful lens for social justice in the Loretta Ross, who came to Georgia Tech, and I talk a little bit about what she said in her talk about Serena Williams. I mean, the talk was much broader about reproductive justice, but she mentioned the Serena Williams example, childbirth example, and I think that the reproductive justice movement that's saying that, okay, we don't need just access to abortion rights, but also the ability to have the children we want to have and raise them in healthy communities is, I think, such an important kind of demand.
It was a radical take when I heard Loretta Ross say it, and not that it's so radical, it's just framing I had never thought. She said, not only do we have the right to, we have the right to have children. Of course.
Yeah.
Sorry, keep going.
No, so I think, so I feel like for me, it's also one of the more hopeful elements of the book too. The fact that there is this really robust kind of movement, and Atlanta plays a really important role in that movement. So, so folks will know activists here.
It's so good. So for those that are listening, again, we're going to open it up for questions from the audience, whether online or in the room. But again, as a biomedical engineer, I encourage people to read this book. It is quite accessible. And when I saw it again, I said, I knew she was smart, but you're so smart because it puts lenses and things that you saw one way, and it gives a different lens, but also gives a whole other frame around it that makes you then rethink about what you knew and how you readdress it. I think it's accessible to everyone, so I just want to thank you for that. And I turn it to our moderators if there are questions or how we should play that.
Yes, thank you so much. Thank you so much for everything you've shared so far. We are going to open it up to our in-person guests as well as our virtual audience. So if you're virtual, please feel free to submit your questions in the chat. There's also an anonymous option if you'd prefer to submit that way. We've got someone over here checking the chat box, and then I'll be walking around the room. So at this time, we're open for questions.
Thank you so much for being here and sharing. Essential worker, the term essential worker is something that we've kind of become more familiar with COVID. I was just curious, do you think COVID has reinforced or kind of revised the notion of essential workers as disposable?
Yeah, I mean, absolutely. And I think this, for me, COVID was another moment where, very similar to September 11th, very different, but in that same way, there was a narrative of, oh, now we're all in this together. But that rested on an invisibility of a lot of people. So, oh, now we all get our groceries delivered. Do we? Who delivers the groceries if we're all getting them delivered, right? There's just this, the real invisibilizing that happens through that language of all being in this together that I think has continued. I guess what's different, though, is that the pandemic has played out in a context of a revitalization of Black Lives Matter. And so that invisibilization hasn't been total in the way that I feel like it pretty much was in September 11th. I mean, there was so little kind of ability to see the ways that the infrastructure was being damaged and the communities are being damaged by the response to September 11th, and by the ways that, if we had taken the case of the deaths of the postal workers and said, what kind of health system would we need to have in order for this not to happen? I mean, the impact on the essential workers would be radically different in the pandemic, right? So, but that wasn't the course taken at all. I mean, so what it meant to be prepared after September 11th was developing high-tech, bioweapons labs. I mean, they're called biosafety, right? Developing all this biosafety research and doing all this preparedness modeling, not building a robust public health infrastructure for everybody, and doctors listening to their patients, and taking seriously those truth claims. I mean, I think that this is something that unites the postal workers and Serena Williams. It's like, who is believed to be telling the truth about their bodies? And, that is part of the essential dignity, I think, that maybe should be part of how we understand essential work. And I think is one of the core arguments of Black Lives Matter. So at this talk by Melissa Harris Perry that Manu and I were at, and Jennifer Singh was there too, and some others, she talked about the way that Black Lives Matter is making that claim, right? That's saying, and it was an interesting thing too, because she was talking about the politics of health in the U.S. South. So she was saying that matter is politics, health is lives, South is Black, and how do we put these together? And I think that that there has become an opportunity to do that much more in the pandemic, but still not nearly enough realized. It has to be a constant struggle.
We have one online. Do you want one in person and one online?
Hello. Hi, and thank you so much for being here. I really enjoyed your talk, and it's great to see you in person. You talk a lot about the healthcare system and racism here in the U.S. How do you compare that to the U.K., where you're from right now? And is there racism over there as well? And what kind of racism? Particularly, I'm asking this as an Indian as well, because I know there is a lot of that happens in the U.K. So how do you compare the two systems?
Yeah, it is such a great question, and a longer one that I have time to answer here. And I would love to talk with you about it further, because it operates really differently. I mean, so the ways that, so in the UK, the discourse is around Black, Asian, and minority ethnic communities. And there's a lot more common ground between Black and Asian communities in the UK than there is in the US. So, and this is not because of intrinsic qualities, and that makes it clear, right? It's like, I think that there's some model minority myths sometimes that say, the reason that Indians on average earn so much more money and have so much more education is because of values or something. No, it's because of post-1960s, post-1965 immigration policies that have structured things in particular ways. And so that plays out differently. And so there is a lot more potential, I think, for Black and Asian solidarities around health. And both are very overrepresented in the National Health Service. And so members of both groups. And so that does create a different dynamic in the healthcare system. But it was really stark in the UK that because the first many healthcare workers who died of COVID, like, you couldn't kind of look at the picture in the newspaper and not notice that they were Black and Asian. And so in a country where they generally don't do these statistics and generally don't talk about racism and health, it kind of couldn't be ignored after the pandemic. And so this is very much a kind of growing question in the UK. It's a longer term kind of subject of inquiry in the US. And it's been really interesting to see how those conversations are evolving.
All right, we've got one from our online audience.
Question is from Julian. Thank you so much. You just mentioned Atlanta has a huge impact in the activism scenario for healthcare and social justice. In which ways you see that, and what would you suggest us students can do to join the activists of the city, referring specifically to undergraduate biomedical engineers, for instance?
That's a great question. I mean, yeah. And of course, undergraduate biomedical engineers are near and dear to my heart. I mean, those are the ones, Manu and I were teaching the same students, right? So I was teaching their ethics requirement and their writing requirement, and Manu was teaching their kind of core majors. And I really think that there's so much that folks can do. I think it depends. What I end the book with, I give an example of an assignment that teachers can use and people can follow that themselves. Then also really encourage people to get involved wherever they are. So I think that those biomedical engineers and others who are pre-medical, I think have a particular role. I think that in part they can change the health profession itself, right? So work towards structural competency and trying to change the culture of medicine. to treat all patients with dignity, but also they have a lot of kind of social standing to make broader demands. Say, you know what, if I care about the health of my patients, that means that we need authentic universal access to healthcare. And I care about the health of my patients, that means we all need access to safe water. And, I think that there's a lot of room for, we've seen, the White Coats for Black Lives movement, right? And so that's been important. And I think also it's important to remember that we're all citizens as well, or residents, right? You don't even have to be a citizen of the United States in order to be active in communities. And so for me, I tend toward the spaces like Karis Bookstore, who provided these books today with the generosity of Georgia Tech. Those partnerships are often those spaces where you can find out about things. So the local politics that are going on, where you can kind of plug in and get involved. And I think it kind of depends on your interests. So you find something that speaks to you. So I've done a lot of activism around questions around policing, advocacy for street-level sex workers and other people who are, those are interconnected, right? So communities that are very aggressively policed and also face many other health barriers to access to healthcare, and also a lot of accumulated insults of the violence that they endure. And so but not, different people have kind of different ways that they plug in. But I think that everyone can have a role. So obviously I'm a professor, and I educate people. And I do think that it matters that you change how you think. I don't think that we should say, oh, that's instead of action. Like, that is part of action. But I also think, it is important to get connected. And so find those spaces on your campus, in the broader community as well.
I just want to add to that also. So one thing that I teach my class and other people is, I think, and I give talks, right, the importance of being a scientist activist. Especially, I think, for all of us, it's really relevant now in these times of COVID, where people aren't believing science. I said previously, I think it's especially important for people in underrepresented communities. But as you talk about global health, what I began to realize that I was getting involved in health across the globe was that global health problems are health disparities for underrepresented minorities in the United States. And so it's really important that people who are parts of those communities, or people who connect with or have friends with or whatever, that I say we out ourselves as scientists, because we're supposed to be able to talk to people about politics and literature and movies and books, but we don't think anyone should have to talk about science. And so we just maybe suppress that if you're in a non-scientist group. But I think if you out yourself as a scientist and then tell people what's happening in science, especially health and medicine, right?
Yeah.
And I think that would really make the conversation more fruitful, especially around the country today with COVID and misinformation. And if they trust you, but they didn't know that you were this good scientist who could talk about it, but you start talking about it in ways that explain it, every little bit helps, and we can all make differences. So that's one thing I definitely.
Thank you for this really important talk. Thank you for your book. You mentioned how when you taught health disparities to your classes, and you started with colonialism all the way to present, people couldn't necessarily relate to the present. So can you contextualize for me what the present actually is? So, let's just take the last 50 years. Have there been times where we've made, a positive impact on these health disparities? And if so, when? Are we on a downward trajectory in terms of health disparities? And, I'm giving you a bunch, so just answer what you want. But, what do you see the next decades looking like, if you had to project it?
Yeah, I think that the biggest things are always the big infrastructural things. So, where when there has been investment in providing safe water to people, where there has been investment in providing safe mail service that can deliver things that people need, including but not limited to drugs. When there are those investments, I think, are those times when it really kind of comes to the fore. I also think the ability of that so often Black medical practitioners and scientists have played such a key role, and so real authentic engagement to actually foster capacity in science and medicine has been really important. And so there have been moments where that happens more than others. And I don't know which direction it's going in right now. I think it's a difficult moment, I think, to see because there's so many different things going on. And it's a little bit hard, the scientific approach, right, would be to say, okay, we need to separate out this impact from that impact and then see, how do we put it as a chart. But the epidemiologist Nancy Krieger writes about this as the accumulated insults of living in a racist society. So you can't just say, oh, well, if there was this program around education or this program about safe food or this program about limiting incarceration, then we could see this thing. And I think that's why we need a kind of all fronts struggle too. So I'm not quite answering your question, but that's because it's a challenging one, but an interesting one.
I have one example, though. I do have one example, and it's going to bring up a name that most people don't think about. Richard Nixon passed the Sickle Cell Act, I believe it was in 1965, which led to influx of funding that started to get everyone in the United States, which is your all approach, tested for sickle cell at birth. And that then led to better health care for people living with sickle cell disease, and their life expectancies began to rise. That's my one example when I study sickle cell disease. So, yeah, it won. Beacon of light.
Excellent.
All right, well, thank you. We have time for one more question, and we're going to read the question on. We'll go in person, two more. We're going to squeeze two questions in, and then we're going to clear out. So we'll start with our online, and then we'll make our way over there.
Sylvia, you spoke a lot about interpersonal discrimination in the medical system. I'm wondering if you can speak to how racism is embedded in specific medical technologies. Are there any instances of bias in technologies and health outcome in people of color, maybe specifically to COVID?
Yeah, I mean, the pulse oximeter is the one that folks are talking a lot about, right? So where technologies are designed, not necessarily attentive to all skin tones. And so we saw kind of systematic undercounting of the decrease in oxygen in people with darker skin tones because of the way technology was designed in not an inclusive way. And I think that, this is, I think that that's actually relatively rare that it's built in such an explicit way. But there are a lot of times when there are assumptions, there are either inappropriate assumptions about difference that are built in. So we see that with, Lundy Brown has written about this with regard to technologies that test lung capacity, and where it's assumed to be that Black people would have a lesser lung capacity for body size, and so things are corrected for race inappropriately. And then you have cases like pulse oximeters, which are designed in a way that isn't actually accurately assessing. So I think, yeah, absolutely, and both are really important.
I was wondering, in what field of healthcare would you say that there's the greatest need for empowerment and reducing health disparities? Like, is it public policy or research and clinical trials or executive roles somewhere else?
Yeah, I think it's a tough one. I think probably there's two levels. So in my department, Global Health and Social Medicine at King's, we talk a lot about how health is more than a medical matter. I think that actually the most fields are the ones that are not necessarily directly around health. So one's about water, one's about food, one's about all of these infrastructures. And then something similar then happens with health. So biggest impacts are generally on things where they're primary care, access to those kind of core things are going to have more of an impact than the more specialized. Although, for patients with sickle cell, for example, right, access to tertiary also matters. I think that as long as we don't say we need to put all of the investment in one domain, I think there can be room for lots, to say, look, we need access to healthier, everyone needs access to a society that can foster bodily flourishing. And then when needing basic care, that's available and accessible with dignity. And we can also, this is a rich society and it's a rich world. There should be room we shouldn't just say, okay, we need only kind of bare bones. We should have access to the high-tech medical care that my colleagues like Professor Platt develop. We should have all of this too. And so I think hopefully it can all go together.